Hello, my name is Liz Gladstone. I'm excited to share with you my capstone presentation titled Operationalizing Trauma-Informed Care in Michigan's Critical Care Settings. To set the stage, I'd like to first introduce and briefly define the term trauma. According to SAMHSA, Substance Abuse and Mental Health Services Administration, trauma is the negative psychological impact of a harmful or life-threatening set of events which results in lasting adverse physiological effects as well as impacting an individual's mental and relational health. And unfortunately, the reality is that trauma is common in the US. In America, 9 in 10 adults have experienced one or more traumatic events. And in the state of Michigan, nearly 7 in 10 adults have experienced one or more traumatic events. While there has been recent effort to increase awareness and recognition for trauma and its impacts, there's still more work to be done in prevention and treatment. In the state of Michigan, there has been an expansion of governmental and statewide initiatives to target trauma and lessen its adverse impacts. One area requiring greater attention is the healthcare system. Not only is trauma prevalent among Michiganders, impacting roughly 7 in 10, but hospital setting provides a unique environment in which acutely ill and injured patients are presenting and are needing an environment to heal safely. Further, recent studies of hospital workers suggest burnout, compassion fatigue, and secondary trauma are more prevalent and possibly on the rise in a post-COVID setting. This is a critical juncture for hospitals and healthcare systems to step up in creating safer environments for their patients and their staff. In the current state, patients are providing valuable insights into their acute care journey. For inpatients healing in acute care settings, greater than 20% of patients develop persistent post-traumatic symptoms even 1 to 2 years after their hospitalization or that acute injury or illness that brought them into the hospital. Additionally, literature suggests that patients who have sustained trauma in the past are more likely to develop greater severity of trauma symptoms and greater persistence of symptoms. Patients and their families share experiences while hospitalized in which they have felt unsafe or powerless, and that their patient-caregiver relationship was fractured due to broken trust. Among hospital caregivers, the day-to-day work can pose threats to psychological and physical safety. For instance, caregivers are often directly witnessing death and severe injury or illness, or the victim of workplace harassment or injury. And in some cases, caregivers report experiencing symptoms of secondary trauma when witnessing patients confront systemic or institutional discrimination. Exposure to repeated trauma predisposes some individuals in healthcare to developing post-traumatic symptoms, which can negatively affect productivity, thus creating unsafe environments for patients and others. It can also lead to reduced job satisfaction and could be a contributor to burnout syndrome and the mass exodus from healthcare that we are currently observing in some specialties in caregiver roles. And the critical care setting, providers and nurses are frequently witness to our most critically ill and injured. In a recent study of ICU nurses, high levels of burnout and post-traumatic stress were reported and felt related to the COVID-19 pandemic. These high levels of burnout and trauma increased likelihood of ICU nurses from leaving the profession. So what can organizations do to prevent trauma onset, the worsening of trauma, or re-traumatization? SAMHSA provides the trauma-informed care framework, which is an approach to mitigating traumatic stress responses through improved safety environment, collaborative support amongst interdisciplinary teams, and opportunities within the structure and of the organization to improve empathy among patients, colleagues, and within caregivers themselves. So next we'll discuss how to operationalize the trauma-informed approach within the critical care setting. So for our methods, I used the SAMHSA guiding principles for trauma-informed care, of which there are 6: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, choice and voice, and lastly, cultural, historical, and gender issues. And in kind of integrating these principles into the actionable approaches, I'm going to also present our program activities for this approach. So starting on the left, we see safety as the guiding principle for trauma-informed care. This approach would include reviewing the environment of care for any opportunities to mitigate alarms or lights that could be traumatizing for patients. We'll evaluate some of the protocols and policies in place on de-escalating agitated patients and see if they are evidence-based and trauma-informed. And then we'll also include a caregiver support group. This is something that is going to cover multiple sort of principles of the trauma-informed care approach, but safety is one of them that the caregiver support group falls within. Under trustworthiness and transparency, the commit to sit and other sort of communication tactics that providers and caregivers can utilize to communicate to patients that they're committed to communicating clearly, trustworthy way, and that they are a mutual partner in their healthcare journey. And lastly, within the trustworthiness and transparency is the consent to treat. So specifically in the critical care setting, patients can sometimes be too ill or sedated to fully consent to some of the procedures. But within this approach, we'd evaluate how we can best obtain consent for specifically invasive procedures or other types of necessary care that could be potentially traumatizing for a patient if they're not able to fully consent to treatment. Under peer support, we'd like to evaluate isolation precautions with infection prevention, as well as some of the seclusion policies, and identify whether those are best aligned with the trauma-informed approach. Additionally, utilizing family as caregiver assistance, whether that be in the critical care setting, helping with bathing patients or oral care, or other sorts of opportunities to leverage family in support. Additionally, adding social referrals, so whether that be referrals for case management, social work, pastoral care, patient experience, just to name a few, but looking at how to provide those resources in the inpatient setting, as well as how to refer to the outpatient after hospitalization to best support the patients. And then again, caregiver support, having caregivers have the opportunity to share amongst their peers what some of their experiences have been, and to help heal from trauma with the support of their colleagues. Under collaboration and mutuality, education about communication tactics for any patient-facing position, routine rounding, so employing caregiver rounding from our nursing leaders and patient experience leaders, and collecting patient feedback and family feedback, and then having a routine process for reviewing that feedback and operationalizing when appropriate. And then lastly, multidisciplinary meetings, so including a collaborative team of intensive care, case management, palliative care, getting all of the specialties involved in one room, involving family and the patient when able, for these sorts of mutual decision making. Empowerment, choice, and voice. So one of the tactics that I think would be an option would be offering choice to patients when available. And then when it's not available, explaining what safety measures are in place that prohibit some degree of choice. So some of that would be in education around how to communicate with patients and family. And then, as previously discussed, rounding feedback. So making sure that the feedback and the voice of patients and their family is being reviewed by not just nursing, but leadership, hospital leadership, and how we can try to operationalize some of that feedback into the organization. And then caregiver support group, again, giving caregivers an opportunity when surrounded by their peers to provide critique, suggestions for how to best support them as they're caring for patients in the critical care setting. So as more of like a work group and reviewing policies, procedures, environment within critical care, while giving them an opportunity to change the environment in which they work. And then lastly, the cultural, historical, and gender issues. So this one would be best supplemented with learning modules and education for any of those patient-facing positions. Next, I'll discuss capacity for the program. So first and foremost, effective program implementation is going to require buy-in and support from the highest level of the organization. For initial implementation, a cross-functional team, and we would want to include trauma educators, nursing educators, provider educators. We need to have IT involved, training, patient experience experts. Excuse me. And then for trauma-informed education, implementing this through coaching, learning modules, and continuing education. And then all ICU caregivers would be required to train not just physicians or nurses, but anyone who is going to be coming in contact with a patient would be required to complete trauma-informed training. So next we'll go over the timeline for implementation. In the first 4 weeks, it's going to cover the assessment of the physical environment. So again, looking for opportunities to minimize disruption, mitigate disruptive alarms and lights. Weeks 5 through 8 will include the in-person trauma-informed care training for ICU caregivers, and then some of the continuing education and modules will begin to be created by the necessary stakeholders. Weeks 9 through 16, we'll start implementing routine rounding by nursing leaders and patient experience experts. We'll begin the process of protocolizing consults with our interdisciplinary teams and including those within critical care order sets. So this would be the standard of care and best practice. Outpatient referrals for social services or mental health resources would also be sort of created, and any sort of opportunities to standardize and make easy for our critical care staff. And then in the weeks 17 through 20, we'll appoint a physician champion to the trauma-informed care work group and begin creating that staff-led peer support group for our caregivers. So there's a number of items that go into a healthy evaluation of this program. Just to highlight a few, we're going to ensure that the environmental assessments are reviewed and operationalized, looking at themes and trends that come from rounding data, and additionally implementing a secondary traumatic stress scale for measuring caregiver symptomology. And this would be something that would be implemented when the trauma-informed care training begins, and then 6 weeks following and 6 months later. And then this would be something that would be reviewed by the trauma-informed care work group and the peer support group. We'll look at percent utilization of order sets and discharge referrals, and then mobilizing established occurrence report systems for anonymous reporting of any behavior that is concerning for post-traumatic response or unhealthy response, and so that caregivers can be followed up with. But additionally, if there's any sort of policies or procedures that seem not aligned with trauma-informed practice, that those would be reassessed in that way. So briefly, use of funds. Most of the budget for implementation is going to go towards salaries for consultants for trauma-informed care, as well as the cost of the in-person and online trainings and the time of the ICU staff. We also have allocated funds for continuing education, materials for education, survey creation, and any sort of documentation for the project. To sustain the operation, it's going to come down to the peer-led support group, the trauma-informed care work group, and of course, if there was an expansion outside of critical care, additional grant funding could be applied for. So reviewing some of the implications of establishing a trauma-informed program in critical care. One, this is going to create a robust structure for the organizations. It's going to prevent re-traumatization within their patient population, as well as their healthcare population. And we're addressing post-traumatic symptoms with evidence-based treatment in outpatient referrals. So we're making sure that we're using best practices when we identify and recognize trauma. We're creating greater opportunities to voice safety concerns, empower our patients and our caregivers when they feel or identify unsafe circumstances. We're reducing post-traumatic symptoms, reducing burnout, and hopefully in turn creating greater retention of our skilled ICU staff. Lastly, I'll finish out with my references included. Greatly appreciate your time. If you have any questions about the program, please feel free to reach out. Thank you.